we have a wonderful, slightly different kind of topic here. I've been interested for a while in the issue of what can we learn from business. And remember one of the prior colloquia, Steph Bertozzi, the dean at the School of Public Health, talked a little bit about that. Talked about how we could learn from how Starbucks models the pumpkin spice chai latte. And so this got me kind of thinking about this. And Colin Boyle kindly introduced me to a couple of our panelists. And we thought we could do a session on, because business is good at so many things, and global health is lacking in so many ways, along with the good things that we're able to do. So we put together a panel, and that's the genesis for this. We're very pleased that Adams Dudley, who's an associate director at the Institute for Health Policy Studies, and an intensivist and a pulmonologist and an internist and a leader in the measurement and reporting of quality of care in the United States, and has an MBA, very important qualification for moderating this panel, will moderate this panel. Thank you, Adams.
Thanks, Tim. And yes, I do hope we can find ways to learn from business. We're going to hear in a second from the panelists. We thought of this panel as an opportunity to see if there was anything we could learn from business that might be scalable and at a relatively low marginal cost so that you could have vast impact with their interventions, and they're going to tell us about that. So we have two presentations. First, to talk about drug pricing strategies, we have Dave Matthews and Jean-Manuel Isare from the Boston Consulting Group, who will tell us about their work over the last year in that area. And then to talk about social media interventions, we're going to have Urmimala Sarkar from UCSF. So BCG team, you want to get started?
Thank you, Adam. Thank you very much. Nice to meet you all. Glad to be here. There's a clicker, I suppose, here. So as a matter of context, I work for BCG on how should companies price things in general. And a lot of innovations has happened about how to price things that many more people could have access to them over the past 20 years with new pricing models. And so I'm going to share some ideas about how pricing differently drugs could actually improve access and improve health outcomes. I'd like to start with some of the basics of economics, and we're going to go fast to stuff that is more interesting. But if you remember your microeconomics classes, you have the usually a demand curve. On the y-axis is the value, on the x-axis is the number of people buying something. And some people are willing to pay a lot, and others are willing to pay less. You usually have a set of costs in the red, and then a company fixes the price in the market at the price points, and it's the same price for everybody. That's the usual picture, and I would try to say here that you have a set of very contrasting situations for all of the different customers buying that particular product. You have on the left with the people on the blue side that are paying a lot less than what they would be willing to pay. You have a lot of people on the right that don't have access and don't buy the product at all. And then you have, in the middle, you have one person that is really screwed, right? They paid as much as what they're willing to pay. They had no choice. I would argue this is a system that comes from the old world of where goods costs a lot and there was labor costs very little on top of that. And there's a lot of ways to do things differently. Let's illustrate how things are happening today in the Silicon Valley, and I'll build up on this. When you get to the red part being very thin, when you get to a business where there's no marginal cost for stuff, you could then allow to have many more people having access and many more buying any product you have. Now, the issue is if you do that and you price everybody at the marginal cost level plus some low margin, you're going to have the green area is going to be very, very small, and there's not that much money to be made. And so the Silicon Valley and many other businesses have invented this model where you have the freemium model where on the right, some people pay nothing, they have it for free, and then you find a way to charge a lot more, some people a lot more. In the software business, that is done via many means and discounting and so on. There's one particular means that I'd like to talk about that then we'll talk about the transfer into the healthcare space. And that's called enterprise license agreements. So think about a piece of software that some people might buy, like Excel spreadsheets. An Excel spreadsheet can be extremely valuable to someone in a company who's the CFO and manages risk, and it's worth billions of dollars to do this well or not. And so software is very, very useful, a lot of value. At the same time, some people down on the shop floor might just use Excel in order to view something. It's very little value. How does a company decide to pay for that, and how does a company like Microsoft decide to charge for that? They don't charge a single price point. They bundle everybody through an enterprise umbrella. And the enterprise agreement is such that you pay an average for everybody, and that average is the average of a really high price for the few people that need the software a lot, and a very, very low price, up to almost zero, to give access to everybody, even if the value is very limited. Okay? So that enterprise license agreement is the way, and software companies have been able to extract a decent value on average without selling all of the software at a very low price point. Another example of this is Netflix and all the media companies. You do not pay at Netflix for seeing one more movies. Netflix pays the aggregate of some people are not going to see the movie, some people are going to see it 5 times, and Netflix buys the movie to the content producers overall on average. They average all of that. Now, if they were to have everybody pay, not everybody would see the movie. The movie is less accessible to a lot of people. So how does that relate to healthcare? Well, here's an example of Hep C and the drugs that treat Hep C. We now have Sovaldi and Harvoni and a lot of drugs that are extremely expensive, up to $40,000 or more. And why are they expensive? Because you have a few patients that otherwise would get a liver transplant. And the alternative cost of treating them is extremely expensive. And so that's why the value is really high. That's the left side of the curve we're talking about. But at the same time, there's a lot of patients that are at the early stages of the disease. And for these patients, the cost burden, the alternative cost of treating them is very low. They're gonna be able to have the disease for up to 30 years without having any alternative costs. And so when the drug is priced at a fixed price, for most people, it is going to be too expensive, and for some people, it's going to be at the right price. The incentives are completely misaligned. So here's the curve of the alternative costs for all of the different patient population cohorts. For some patients on the left that are really at the later stage of the disease, the alternative cost is really high. For some others, it's very, very low. Whatever the price you set at the fixed price, you will always have a lot of people for which it's not going to be economical to treat them. Right? And that does, of course, so today, what has happened? Well, what has happened today is in most of the countries, even the ones where the payers have said they would treat everybody, they can't afford to treat everybody at the high prices that are there. If you were to treat everybody at, roughly the $30,000 or $40,000, the burden for the country about paying for everybody would be much too high. But the marginal cost of the drug is extremely low. It just costs less than a few $100 to actually manufacture this. So in theory, there is no reason to be able to force this, to not be able to treat people because of the pricing model we have. Right? The alternative is to do the equivalent of the enterprise license agreement that I was talking about before. What if a particular payer was to decide to average out for everybody and so pay the entire green area as the fixed costs? right? So the idea here is instead of paying per patient, you would pay for an entire population. It would look something like this. Today, on the left, each time you treat someone, it costs $30,000 to the payer to treat that person, or $40,000, or $25,000. It's very expensive. What about you decide that you pay an amount, around $350 million a year, which is roughly the same as what the healthcare company will have today, the biopharma company. And then you say, we're going to make the drug available to absolutely everybody at no costs. When you do that, you have a lot of really good and interesting things that happen. First, instead of staying on the current trajectory, which is in spite of having the drug, and it would take 2 or 4 years to treat everybody if you know everybody who are there, if you can identify them. Today, we're on a path to treating people, roughly half of them by 2025, and maybe 2040, 2050, the goals for the WHO are not going to be achieved. If you had this new pricing model and you just made the drug available for everybody today, you're going to go through the backlog of treating people. Of course, the most severe levels you treat first, but essentially you could treat everybody within 3 to 4 to 5 years. And the outcome for a total cost system and the savings will be massive. For a country of around 50 million inhabitants, you would save around $3 billion, right? So we cure people, we save $3 billion, and someone will say, but what's the incentive for the biopharma company? Well, the incentive is you can actually price the green area so that they would make slightly more than what they make today. Win, win, win. Right? But you need to think through completely differently how the prices are set. And you need to abandon this idea that two people need the same drug would essentially pay the same price. That mechanism allows to have a de-averaging view where the people that are the sickest will essentially drive a higher price point, but the people who are not sick drive a very, very low price point up to the marginal costs. So this is the situation for Hep C. Does that apply to other domains? We think it does. Each time you have a curve that looks like this, where you have a lot of variations of cost between different individuals, you could re-average that and have the payer pay a fixed price as opposed to a price per individual. Each time you have a disease where you have different stages and timings of costs, asking the payers to pay now for savings that are going to come 20 or 30 years from now is something, of course, that's going to be really, really hard to do. But if you average it out and pay over time, you could solve that particular problem. So each time you see a vast variations of value or alternative costs for a particular disease and a delay in time that misaligns the timing of curing the disease from the cost of saving saving people, you will have a good opportunity to think through alternative models, and they will drive better impact both in curing people and deaths as well as in lowering the cost overall for the system. That's the main idea. I thought I had 1 minute, but anyway, so that's okay. So that's the main idea here. I went a little bit fast to get it. I'm looking forward to the conversations, but the idea is if you rethink the entire economics about how value is exchanged, you could have a massively better equation about how we cure people and how we do it in a very cost-effective way. Thank you.
And now for something completely different. Erimala?
So I'm neither a business person nor an economist. I'm a primary care doctor and I do health services research. So I'm really interested in improving the health behavior of diverse populations. And what I want to talk with you about, and in order to do that, we have to spread and scale, right? We can try things in academic settings on a small scale in tailored ways, but we have to reach a lot of people. And I'm really interested in using social media to understand health risk and deliver interventions at scale. And the reason that I'm part of this panel with people who do things that are completely different is because the hope is that this approach is informative in sort of the same way that in the sense of learning from business. So that's how I feel like we tie together, and we can think more about that as we go along. So I'm just going to speak about the framework, the way that I think about this. I'm going to try to convince you that this is a good idea, and then I'm going to give you a couple of examples, and we can talk about it. It's not a data-heavy presentation. After lunch. Okay, so what I want to convey with this slide is that social media is the way that we communicate. And all of these statistics are from the US. 69% of adults use social media. 90% of 18 to 24-year-olds trust medical information shared on social media. That's a little disturbing. 40% of consumers say that information found via social media affects how they deal with their health. And 88% of businesses use social media for marketing purposes. So for all of us who do public health, who want to improve public health, we ignore this at our peril. Okay, that's my first message to you. So why am I talking about social media in concert with vulnerable populations? We know there's a digital divide. I know that in my primary care clinic at the Richard Fine People's Clinic at San Francisco General, my patients often don't have a smartphone, may not be on social media. Why am I still talking about it in this context with all of you? Of course, in the global context, access to the internet very, very much occurs over mobile rather than any other mechanism. So it's very important, and it overcomes barriers of time and distance. I think this is particularly important in settings where the actual infrastructure does not permit communication. And I'm talking about things like having a state-controlled media that engenders very little trust, or not having reliable landlines or other communication networks. The reliance on this medium is even more. And why would we want to use this to do health communication? Well, it's got a lot of potential, right? You don't have to hand someone a piece of paper to try to get them to do something. It's about the worst way to change behavior. Instead, you can use audio, you can use video, you can do responsive learning. So people who want more information and need more detail can get that, while people who need repetition and need to get to competency at a certain series of skills can have that repetition and iteration until they're ready. It improves access to peer support. I have a patient who is a caregiver for her elderly mother with Alzheimer's, and she's also monolingual Spanish speaker, and because she's low income, she has no respite care. She would not have any caregiver support if she did not have a Facebook group of Spanish-speaking Alzheimer's caregivers. And now when her mother is agitated in the middle of the night, she can reliably go to Facebook and share her challenge with a network of supportive peers. And that's something that's not available in real life. In terms of scaling, there's a lot of advantages of social media. One is there's the potential for automation, right? Sometimes we do interventions and we really need to know, for example, if we're doing a hypertension intervention, whose blood pressure is in range and out of range. If you are doing a sort of mobile-enabled intervention where you're getting signals and can make decisions in an automated fashion, what you can do is have triggers for the actual healthcare worker support. So then you have one hypertension nurse, and instead of calling every single patient with hypertension and asking them, what was your blood pressure this week? She automatically gets the list of people to call whose blood pressures were out of range and can serve a much larger community. So these are some of the reasons why I think that vulnerable populations and social media research are a good fit. So how do we do it? Okay, there are several ways to think about this, and I'm going to describe 3 types of research that leverage social media for public health, and with an example. So on the right side of the slide here, you see that we have people in the world. And they're doing their health, they're doing their exercise, they're communicating with people in real life, and they're communicating with people virtually. And all of this is creating information, right? The other nice thing is that interactions that used to be in person that could never be captured, if they happen online, we can sort of spy on them as public health professionals, and we can get insights into behavior that simply would not be available to us in the real world. And that content is this rich source of information that can then identify what we should be intervening on. And I'm going to give you an example. Okay, so we did a study recently where we were interested in opioid misuse. For obvious reasons, it's an epidemic, and we wanted to know more about it. So our initial study we did with Twitter, and we looked at a lot of what people said on Twitter about opioid misuse. It was very disturbing. And then it led us to this Instagram study. And we chose Instagram because it's the most popular platform among young adults. And that's the group that we want to intervene on. So we asked ourselves, to what extent is codeine misuse represented on social media, and how is it characterized? So this is an example post. I'm pretty sure my staff chose this particular image because they know I'm a big fan of Neil deGrasse Tyson. I don't think this is actually what he was intending when this image came to light, but there's a few things I want to share with you. So when you combine codeine-containing cough syrup with soda and candy, that creates a abused substance that people call lean or drank or purple drink, is often depicted in that way, purple liquid in a double styrofoam cup. And it has been linked with a genre of music, a particular hip-hop genre. And a lot of the posts that we saw was sort of a way to signal that you are part of this tribe is to broadcast your abuse of this substance. So that is upsetting, but it also lets us know what is the context in which this misuse of prescription medications is occurring. And there's no way that we could learn this by pulling people into a focus group and asking them about their prescription medication misuse. We just simply wouldn't know. And then just for some additional interesting data, you'll notice that some things that raised my blood pressure when I saw this were the related hashtags, so the related words that were co-occurring with codeine misuse, or many words related to marijuana. You see benzodiazepines, so of course the combination of benzodiazepines and opioids is particularly dangerous. So it was very disturbing to me to see that came up together. But you also see the name of a rapper, you see luxury, and it gives you a sense of how aspirational this kind of drug abuse is. And that means that when we try to do interventions with young people to move them out of this space, we need to understand what's bringing them in the first place. So this is data this is a place we couldn't go without social media. Okay, I'm going to speed it up. All right, so other things that people do, automated text analysis can only get you so far. That's what I want to say about it. You actually cannot interpret, this data would not be meaningful if there weren't a person looking at it. This is really still in the space of mixed methods. And it requires interdisciplinary collaboration, definitely not just for me. You can also imagine social media being used for public health campaigns. Instead of a billboard about healthy nutrition, you deliver this content that you want for people's health behaviors to where they are, which is online. And I'm going to give you one very smart example from a colleague, Eleni Linos, who's a dermatologist here. She's interested in preventing indoor tanning. So she's got a collaboration with Google Ads. If you Google indoor tanning, she has convinced Google to give her free advertising space for anti-tanning messages. So that's a perfect way to target the people who are at risk for the behavior rather than just having a billboard up, right? It's much less expensive, and it's much more targeted. Okay. I'm going to skip that slide. The last type of, and I think the most interesting type of scalable social media health research are interventions. So in this, we imagine that we're overcoming the challenges of healthcare access by reaching people online and connecting them with clinicians or a program that we think will improve their health. And I'm working with another colleague who is a psychologist, and she does smoking cessation interventions. And you can actually, she's had good success delivering them via Facebook. So people actually can get their cognitive behavioral therapy for tobacco cessation delivered online at a much, much lower cost, and people who wouldn't necessarily want to come into a clinic. You can also tailor for language literacy. We're doing a study now where we're tailoring for sexual and gender minorities who have a much higher smoking prevalence, and having those online groups is almost like having safe spaces for different populations. So I've got less than a minute. I'm just going to tell you the challenges and what I think the opportunities are. Online is not equal to real life, right? We don't know who people are online. They're not always real people. It's not representative. Platform choice is really important and not straightforward. I've shown you studies in different platforms. The medium and the message have to travel together in concert. There are a lot of important implementation considerations. I'm really happy to talk to people about this offline. You can't just say, oh, I'm going to do the diabetes prevention program, but online. You actually have to tailor the program to the platform. Think carefully about the demographics, engagement with online, just in the same way most people never use an app after they download it to their phone. It's hard to get, when you are doing an online intervention, you're competing with everything else that person could be doing online. So recruitment and retention and engagement have their own challenges. And I'm also going to acknowledge that all of the things I've told you are much more about potential than proven impact today. I'm hoping that this is interesting enough that some of you will engage in this research, focus more on long-term outcomes, and figuring out how to really do this work right, because I think the potential is there and it's worth it. All right. So let me see if I can. Sorry, guys. I'm going to stop there, and I'm going to thank you all for listening. If this is of interest to you, we have a symposium here at UCSF on social media and health in December. Love to see all of you there. And I'll be happy to take questions with the rest of the panel.
Thanks, Mala. This is a global health and economics conference. And in fact, I would argue that these were actually two economics talks. One was more obviously an economics talk, in the sense that Jean-Manuel was talking to us about how you price a particular service, addressing actually a quite narrow market, where there, in the instance that he gave us, there's one disease that he's focused on and the treatment for it. In fact, healthcare happens also in a much broader sense that Mala was addressing, in that true healthcare is a bundle of many different kinds of services, and the decisions that patients make are actually economic decisions. Even when you're talking about people with very few financial resources, if they're not paying, even if they're paying nothing of their own money, they're nonetheless choosing to invest their time and effort into either paying attention to what it is that you're putting out there, or paying attention to something else. And in fact, we need, one of the things that I think economics contributes to this field is sort of a always in the back of your mind way of thinking about things, that in fact these are markets, these are constantly markets. So Jean-Manuel's proposal is to take a way that markets function, in which when you reach an equilibrium price, you reduce the market to essentially a single transaction across the population, and say, now I want to break that market up into a bunch of equilibrium prices for a bunch of small populations, and then take the average of all of those. And it's very interesting. I think one of the key things that we'll want to hear about, and I'll start with our first question for you there, is you priced everything, so you created more green area, and then you price things based on the size of the green area. And one of the very important social conversations I think we need to have is that green area is traditionally called consumer surplus. The additional benefit that the consumer gets, not the supplier gets. And when you do your calculation, say the consumer surplus, if you stretch it out like this, would be this big, we have to ask who gets how much of the green area?
That's exactly right. There were two areas there. There was a blue area and there's a green area. And the blue area was the consumer surplus. And you could see the blue area was actually pretty.
I'm sorry, I got the colors wrong. Yes.
Pretty big. But then there is indeed a green area. So there is a dialogue and discussion is worth having about how to split the value that is adding. And here I wanted to posit first that the main change I was advocating for is a change in the way we set the prices, and so not a price per individual or per pill, but a price per population. Usually, so that's not setting the price points, that's just setting the price formula, the per what you price. The market forces can then determine how the things are going to be split. And so usually when you have only one provider and nobody else has any alternative, that provider could get the green area to be a larger proportion of the outcome. But if there is 2 or 3 and 4 alternatives, then suddenly the green area is going to tend to, with competition, tend to be set lower at a lower level. So with the argument I'm making, I'm just focusing on how to price as opposed to how to set the price points, knowing that in different circumstances the exact prices are going to set in different ways. Now, in our model, we actually decided to set a price in a particular place. And we did it by saying, in order for the biopharma company to consider something different, they need to make at least a little more money than what they make today. Otherwise, why would they change? And we know that the way they price today is very counterproductive from an outcome perspective, from a health outcome perspective. Higher costs, as I talked about, and a lot of people that are not treated. And so we decided to set up these proportions so that the biopharma companies would get roughly between 5 and 10% more than they get today. And then you get a massive surplus that is now getting into the system with lower cost, the $3 billion I was talking about. And then not quantified, but even more important are the deaths that you avoid and the number of people that you cure that won't be sick.
So let's take a couple of questions on that, and then I'm going to pivot to Urmi Mala, take a couple of questions on that, and then throw the floor open. So,
can I make a quick follow-up
sorry,
question?
go ahead, Kazi.
So, one of the things that I really was impressed by that model, for biopharma today, a big cost is customer acquisition. So if I'm selling these drugs at $14,000 a pill, it's my responsibility to create the sales force that's needed to get patients on the pill. In your model, once you move all of the cost, it's a lump sum payment, that is a huge saving for pharma. And that might be an incentive for them to come on board, because now the customer, once as a health system, it's my responsibility to get the patients on the pills. I've already paid for them.
That's right. That's really interesting. So we think there are many ways to implement this. Some of the ways to implement that would be by giving the biopharma an incentive to still compete and get the drug out there. So for instance, if a country was to say, this all green area, that's what we're willing to spend, and we're going to pay to the two pills, to the two providers, in proportion to how much the doctors are going to prescribe them. So you still have competition for people to get that, right? But you don't have any more costs. So treating one more patient doesn't cost you anything. Therefore, suddenly nobody is thinking about, well, let's limit access because it will cost us too much. So you take this out. So there's all sorts of ways to do this, but excellent question, that's right.
But if I understood you correctly, you introduce a new cost of needing to monitor the doctors, not to just generate patients that are taking it.
Well, but monitoring the doctors is not that hard. Because you no, but let me explain what I mean by that. You actually don't monitor the doctor themselves. You look in that particular country, how many pills from one brand and how many pills from the other brand were sold. They're sold in the pharmacies. And then you have stats on that are really not hard to get to. And then you split the total fixed payment between the two firms depending on how much pills were prescribed one or the other. You still have the competition between the pills on which is the best, which cures people. And then the money is not depending overall for the country on how many people you treat. You treat everybody as fast as you can.
Okay,
There's a second point to
question.
Kazi's question. One more point to that.
Sorry.
It actually aligns incentives better as well, because as we talked about, there's the two pharma companies that might compete. There's also the payer, right? And the payer is incentivized to get as many people in as possible, right? This is about universal treatment access. And so by creating a screening program, they actually get so much more benefit from the pharma companies, right? So we've actually seen, for example, in New Zealand, there are cases where the New Zealand government will pay about $100 for anyone who wants to get screened, particularly from certain groups for hepatitis C. And you could imagine that kind of a program would actually be financially quite beneficial to them, because they're actually taking all of these extraneous costs to come later, and $50, $100, it totally makes sense. So.
I'm feeling some hepatitis C coming on. Yes.
I think your model maybe worked really well with the countries that has a smaller scale and in universal healthcare, for example, like Korea. You can see it's those kind of pricing policy works perfectly, right? But then, how do you imagine that those kind of pricing policy would be applied in like U.S., where there's like different payers and then
This is an excellent question. So we've thought about this. So first of all, most people don't live in the U.S. And therefore, solving the problem there is already good. Now, in the U.S., when you start to look at it, you indeed have an incentive problem, which is you have multi-payer system, and patients move from one payer on average every 3 to 5 years, which means the incentives of saving costs 10 years from now is not really there. That's a problem that particular pricing model doesn't solve. Now, if you look a little more in details, you still have in the US some payers that have the long-term interests of the patients from an economic perspective, not just from an ethical perspective. And so think about the Veterans Administration. They're going to care for people forever, right? Think about Medicare. And so already with these two, even within a multi-payer system, you already have a significant proportion of the population that can be dealt with there. Now, if you wanted to apply this model really across the board, you would have to set up some kind of pooling system across several firms. If only one payer adopts this and the others don't, you could have the issue of adverse selection, where everybody with Hep C would go and get a health insurance with that payer. Which creates. So I don't have the solution for that, but it's not completely irrelevant even in the U.S.
So I'm going to now pivot to Urmimala's stuff just to make sure we get there, and then we'll throw things open in case there are more questions. So the economic lens that you can use to look at Urmimala's topic is that actually it's legitimate to consider every human interaction from an economic framework. People do have to decide, even if they're not paying money, they do have to decide what to do with their time and their energy and their effort. Then if we dial back to Econ 101, you remember how markets work. Information is actually critical to the functioning of markets and to the decisions that people make about how to spend their resources. And so Urmimala has brought up the idea of finding scalable, very low-cost ways of changing the information available for people as they go out to engage in any kind of activity, all of which can be viewed from an economic lens. So let's see some questions. Yes?
Thank you. In regards to your presentation on your point on drug abuse and use of lean and using social media information, with any information or any data, there's a lack of context and cultural competency when reading it. So with like the hashtags that are trending, one of them was ASAP Mob. And ASAP Mob has a huge campaign against drug abuse, as they had a close friend of theirs die from drug abuse. So that's not a good representation, because you just see that and you correlate it, oh, she's talking about lean abuse and so on. And then there's also the issue of self-medication within populations that abuse lean, within certain genres of music and so on, and certain individuals who sing about it and don't actually do it.
Right.
So if you're using social media, which can have benefits, which are example as the Alzheimer's group and so on, but at the other end, if the wrong person or somebody that doesn't have the context of the information is using it and it could be abused or misread or paint an accurate picture of a group.
Right.
How do you combat that, or how do you work around that?
Yeah, and actually what we see a lot is there's this disconnect between a lot of people. What I think is really interesting, and you're absolutely right, so that's why you have to have actual people who are culturally competent doing this research, right? You can't just have a machine learning algorithm that's going to show you all the hashtags and then assume that you know what it means, of course. And I think it's a much more nuanced discussion that I didn't have time to go into today. But one thing that's really interesting is that we see a lot of appropriation of specific cultural content tied to drug use on social media in a very aspirational way. So you have you have a clear understanding that a way in which someone is trying to emulate something that is outside to them, they're using social media to kind of identify with a group. And you are right, when that happens, you very much see a misrepresentation. And that's definitely a big part of what makes this research really challenging, and why I make the point that it absolutely has to be mixed methods. And the other thing that sometimes, if you're doing something that's like a hashtag analysis, so it is possible that ASAP Mob, for example, that if what we do is we would pull out those individual posts and we would read them, and then we would see that the hashtag is in fact perhaps really anti-drug, right? But it uses that hashtag. So you have to be looking a little bit deeper than just a bunch of counts, is my answer to that.
Another question?
Hi. Thanks for the presentation, Ermi. Given what we've seen with how our political campaigns have been redirected through social media, what I found really interesting about your work is that it's one avenue of thinking about trying to do public health, using it as it is. But I'm wondering if you're seeing, and you think there's an agenda in public health, this is obviously a leading question, about the regulation of social media and whether the impact of what we can do in public health might be larger in a sense if we could control at the source the way social media is regulated, as opposed to trying to work within the conniving world that it is in a sense. And I mean, maybe both are necessary, but I'm wondering whether you think the main effect might be by first trying to create an argument about the public health benefits of regulating social media rather than working within clearly a twisted set of rules of how it's currently functioning.
Well, I certainly agree with you that it's a twisted set of rules. And I also will say that it's been remarkable to me that there are groups on social media that very quickly twist public health campaigns. So you can see there's an anti-vaping campaign that came out that had very distinct branding and iconography. And within 18 hours, there were pro-vaping tweets, Instagram posts, Facebook messages that exactly copied the iconography. And it was really remarkable how, and I think that's actually, it reminds me of the tobacco papers, right? It is remarkable what a stranglehold there is by certain really anti-public health forces have on our dialogue about health behaviors. So should we be advocating for regulating that? I think the first thing to do is very similar to what was done with tobacco, which is just shining a light on how deliberate and corporate sponsored and kind of scary it is. And then perhaps the pathway is more like tobacco advertising regulation. It's certainly possible. I think knowing how invasive and pernicious it is the first step.
So these two presentations highlighted how incredibly complicated our society has become, and how we might need to actually rethink a lot about our traditional economic models. So everything in economics, whenever we draw supply and demand curves, we sort of quickly say, assuming perfect information, and then ignore that assumption. And Urmi Mala and the questioners are pointing out that, wow, that's a hard assumption to actually have be true in the real world. And then Dave and Jean-Manuel are saying, well, maybe we actually need to rethink the fundamental tenets of capitalist markets and ask, does it make sense for everyone to be functioning as individual purchasers, or is there some way to take a population perspective? And then you immediately have to ask, well, who takes that population perspective? And you can see how much more complicated it is in the United States than in Korea. And even those purchasers then will fall back into the same information trap and the same information problem that Urmi Mala, through social media and a variety of other ways, we have seen many governments around the world many times believe things that were simply false. And if false beliefs are directing group purchasing of drugs, then a lot of bad things could happen. So, any questions on either presentation or linking the two? Yes.
So Lou Garrison, health economist, University of Washington. Been there 14 years. Before that, I was head of health economics and pricing at Roche in Basel. Okay. So, as you all know, economists we've long advocated differential pricing across countries. It's very frustrating that we haven't solved that problem. To some extent, it took a long time to solve it for HIV, but we did, in a way. But if I understood you correctly, essentially you were advocating a patent buyout. Instead of giving, for Gilead in that particular case, I know you're trying to look to a broader model, but you said let's offer them some amount of money, a stream of money for 10 years, we'll buy out their patent. The problem with patent buyouts, well, if we buy out Sovaldi, what do you do about Harvoni, Vakirpak, and all the others? So how do we manage the patent buyout stream? And you're talking about we don't have a buyer for the world yet. In fact, we'd be nice to buy it out and make it at marginal cost for everybody in the world. So
Bill Gates is trying.
Well, but they've had a lot of trouble with advanced purchase commitments, I think, for the same reason that it's very hard to see how to do the auction over the first few entrants, and the second and third, fourth products are better than the first product. So so there are two big problems there: the patent buyout and who's going to do it? We're not organized to do it, okay? But at the same time, Gilead has done differential pricing, right? I mean, they basically have set it up, competing Indian generic manufacturers for low-income countries. So at the same time, we're very short. Here's a disease we could eradicate if we just got our act together. So it's very frustrating from that point of view. But I like the idea that you're suggesting alternative ways of thinking about pricing. It's a big issue. So.
The other thing that as soon as you get to the patent buyout thing, you immediately raise the question, wait, is this just a utility model? And should we just regulate this like we regulate other utilities? Manuel or Dave?
Well, yeah, actually, I would argue that at the stage where we're going in the economy, we should all think about pricing stuff without worrying about costs. Costs are largely becoming irrelevant. Most of the innovations comes from smart stuff, and smart stuff and software, AI, and all of that has no marginal costs, and therefore should not worry about the cost at all. But let me try to address more directly the patent issue. So yes, from a pricing model perspective, so the formula of the price point, it looks like a patent buyout. I was trying to be careful to not go all the way there and to say there still needs to be a competition at some point between, let's say, the AbbVie medication and the Gilead medication. And at some point, there needs to be a mechanism to decide which adds more value. Is it equivalent or not? And I'm advocating that the country thinks about what are the savings that I'm going to get from treating everybody, which we know is now possible. Consider then that a max that they want to pay and say we actually want to share the value that we're going to create by this. And so the entire value should not go to Harvoni and Sovaldi or the other drug manufacturers. And let the drug manufacturers compete about how much share of that savings they should have a right to. Right. So there's all sorts of complications there, but essentially still trusting, I'm not trying to replace market. I'm trying to have markets work on a different basis instead of being per patient to be per population. Now, since we happen to have split the world in a bunch of countries, you could have a bunch of competition between these two players, country after country, which will then itself get to an equilibrium price points on the price per population. And I think that could get to an outcome that is not that bad, actually, because you have enough data points and you don't have, the number of countries you have and the number of payers will get to an equilibrium that have enough sample size to get to a market price that probably will be fair.
So I know, I see a lot of hands, so sorry. I know this conversation could continue, both these conversations could continue for a long time, but I also know that the next presentation is going to be great. So we'll switch to that now. Thank you very much.